let me make a description of the anatomy and how to do the ablation. This is the number of cases we have done in pen and here. This is a relatively new field, so if you read the literature, there are no specific descriptions about apical arrhythmias of the right ventricle. You can see in the first case I'm going to present, this is a 23-year-old patient, woman, with incessant ventricular tachycardia refractory to amiodarone and beta blocker with 2 failed previous ablations in the septal and apical area of the right ventricle in the first ablation attempt. The second one was an inferior and apical origin of the right ventricle. This patient was referred for ablation. She had no relevant history, normal echo, normal resonance. This is the baseline ECG. Not many significant findings, and this is the ECG of the tachycardia. Due to time limitations, I am going to describe it very quickly, saying that she had a pattern of left branch block. It's very important that consistently there is no transition. There is negative concordance from 1 to V6. The axis is superior. From 3A to F, it's totally negative. It's almost a QS. And it has a positive lead 1. So it's the upper left axis. This is the second case. We compiled a 58-year-old patient with ventricular tachycardia, presyncope, with tachycardia with no relevant history, normal echo and MRI, referred for ablation. The ECG showed no remarkable changes, and this is the ECG of the tachycardia in this patient. As you can see, the V1 morphology is left branch block with negative concordance, with no transition, and once again, the upper left axis. If you see D23F is totally negative, such as QF, and the pattern is very similar to the previous case. The third case is 64-year-old female with previous VT ablation, ventricular arrhythmia, device was implanted, no relevant history, normal echo and MRI, and she received frequent ICD therapies. She was referred for ablation. The baseline ECG showed no relevant findings. And this is the ECG of the tachycardia in this patient. Here you can see once again the consistent pattern of left branch block with no transition. So there is negative concordance on the upper axis with QS 2-3F and D1 is positive, suggesting probably that the upper axis is to the left. So here you can compare the 3 cases. The patterns are similar, as I described before. You can raise your hands. I don't think we have time to vote, but Andrea, you can tell me which is the favorite answer. Which is the site of origin based on this ECG? 1, moderated band, apical crux of the heart, septal of the left ventricle, or apical of the right ventricle? Please raise your hand. Those who are in favor of 1? No, vamos a votar por el 1. Por el 2.
Energies.
And the apical RV. Okay, so the majority is between moderator band and apical RV. The majority apical RV.
Bien. Muy bien.
Then second moderator band.
Obviously, there is a bias here because I started my presentation by describing this is an apical right ventricular arrhythmias. Well, anyways, but lo más importante y por lo cual colocamos estos diagnósticos es porque en efecto pueden ser parte de los diagnósticos diferenciales.
In fact, these can be part of the differential diagnosis in this type of cases. In the ECG analysis, In order to explain this type of arrhythmias, we must keep in mind that first of all, the left branch block pattern without transition, in other words, negative concordance, suggests that there is an apical origin arrhythmia, so that all the precordials, as you can see on the slide, are across the apex and they mark negative. The force vector must be removed from all the precordial. And the other important aspect is that this is a morphology of left branch block. In a way, this suggests that it could be towards the right apex. And now to make the differential diagnosis with the moderated band, what's important about this is that in the moderated band, usually, whilst these are left branch blocks in the morphology, there is a late transition. Practically always the transition goes to B5, B6, as you can see on the right. I am trying to understand it. I hope that you can see the image here. We can see the moderator band, very small on the CT, and I try to understand it to be able to differentiate them. If we have something purely apical, everything is negative. If something is originating in the moderated band, part of the activation goes towards BCs with a late transition. In order to understand why these arrhythmias are totally negative, we just can imagine this area of the apex of the right ventricle. Here you can see, or you can explain rather, how a force vector will depolarize in this area upwards, giving D2, D3, ABF totally negative with no initial positivity, but additionally depolarizing to the left, and this explains why D1 is positive. But contrary to what happens in the outflow tract of the right ventricle, where AVL and AVR are totally negative, saying that it's a very high structure. In this case, the fact that AVR and AVL are totally positive suggests the contrary, that there is a very, very low structure depolarizing upwards. This is one of the differences from our point of view. For moderated band tachycardia, the moderated band has negative predominance in 2 of 3 AF, but usually they have an initial positivity. And we understand that on this chart. I hope that you can see it in yellow, dotted line. This is the moderated band. You can see it here. And when it depolarizes, whenever there is an arrhythmia of the moderated band, one part of the vector comes downwards, explaining the 3AF, and the other one moves upwards to explain the negativity in the QRS. Finally, to differentiate these arrhythmias from the crux to the base of the right ventricle, this is an ECG of a publication on crux arrhythmias towards the base of the ventricles. And here you can see that while there is a D1 positive and D3 AF totally negative and a B1 totally negative, there is an early and progressive transition. There is no negative concordance in this case, and this happens in the crux different from the apex, basically because in the crux to the basis depolarizes towards the precordial, with a transition to B2, B3, and becomes positive in the rest of the precordials. There is a paper by Gerferstein. I don't remember whether he was at Payne at that time, but he differentiates the crux into basal and apical of the crux. It's not an exact or accurate term, but he defined it basically when we found the origin of the arrhythmia with a catheter in the posterior interventricular towards the base, or more distally to the vein, suggesting that it was distal to the crux. He describes them in this way: D2, 3, AF totally negative, D1 negative, but they make a transition, an early transition at B2, and that gives a pattern break of the activation of the precordials that somehow suggest epicardial origin. This is a workflow And this is my proposal, to be able to differentiate this extrasystole with left branch block in A1. Basically, look if there is QS in D2, D3, an AVF or not. If it's not present, start with RS. This could be moderated band. When we say that there is, I'm sorry, I don't see the slide.
In
QS, we need to do this next question. Make the next question. What is happening in VS? If there is QS in VS, it means it's completely negative concordance, and that would suggest that there could be apical in the right ventricle, as in the three cases that I showed where the electrocardiographic patterns are very consistent between the three cases. When the patient has left branch block in 2, 3, we have completely negative QS, but doesn't have a negative concordance, but on the contrary, there is a late transition towards V6. And then, no, sorry. Sorry. I'm all confused. I'm seeing my presentation through a window, but when they have RS or QS in V6, as is this case, or this other case, then the question that we need to ask is what V2 is like. If V2 has RS, maybe it will be described as apical in the crux, as in this case. So I repeat to clarify the point because I think I confused you. Left branch block, QS in V2, V3, AVF, but aside from that, positive V2. These are the apical of the crux, unlike those that are real, true apical of the tip of the right ventricle, where there is a left branch block, QS in V2, V3, AVF. Concordance, a negative concordance, completely negative. There is no pattern break and not completely positive V2 as in this case. So let us talk about the anatomy of the right ventricular apex to understand how to map it. And based on the descriptions of McCullman and the anatomical descriptions, we can say that the apex of the right ventricle is a structure that is anterior, as you can see on this chart, obviously to the right of the apex of the left ventricle, and somewhat inferior. The apex of the right ventricle, as you can see here, is inferior to the apex of the left ventricle, as we will see. And this is critical to recognize it on ultrasound. On echo, here you can see another of McCullman's images where you see the apex of the right ventricle. This is basically a recess. In fact, it is called the apical recess of the right ventricle, which is highly trabeculated. You can see here in the image how trabeculated this area is. It is a recess that points towards the left ventricle and has two fundamental components which need to be understood to map and ablate these arrhythmias. A septal component, the back wall that is part of that recess, and a component of the free wall, which is towards the inferior and the anterior aspect. You can see in this image here you see the two components of the apical area of the right ventricle. You can see the septal part in blue and the free wall part in red. This is another section where you can see the apex of the left ventricle here, and here you see the free portion, which is higher, and the septal portion. Since it is a tip, this area lends itself to perforation, especially with devices. These are two of the areas where there can be perforations. You can see towards the tract there is one in the anterior recess, and here is one which is the apical recess of the right ventricle, where frequently these are the two places where you see the perforations caused by devices most of the time, as is the case here, which was tweeted by Rob Schaller. You can see the anterior aspect of the tip of the right ventricle, which is precisely where the electrode is going through. It is important to recognize also that the tip of the right ventricle, its structure, its important neighboring structure that we need to remember is a moderator band, as you can see here. And in fact, it is the one which many times prevent us from passing electrodes or catheters to the right, to the true tip of the right ventricle. When we place devices, almost always we feel obstruction to the advancement of electrodes or catheters. And you can see on this image here to the right, precisely the moderator band. You can see the apex and you can see the moderator band connecting with the anterior papillary muscle. And here you see it here, an ultrasound, an echography, the moderator band, and here you see it also. And through here you can advance the catheters to go apical. Now regarding how to map, bearing in mind, well, I lost my pointer here, but considering or bearing in mind that this anatomy that I have explained, we need to understand that advancing the mapping and ablation catheter to the tip of the right ventricle is not always easy. And obviously, using IC is very useful. You can see the tip of the left ventricle on the screen, the tip of the left ventricle here, the right ventricle here, and you can see here precisely between the tip of the left ventricle and the free wall, we find the apical recess of the right ventricle where we can advance the catheter. And on fluoroscopy here, we see an injection from the irrigation catheter and how it reflects this anatomy very well of a recess of the tip of the left ventricle. We think that one of the serious problems of why these procedures fail is because we cannot adequately identify this anatomy, and almost always the catheter comes to this area in front of the papillary muscle, but never is it advanced so distally as is required in order to arrive at the true tip. In this procedure in particular, in the first one, you can see that the activation found here during the arrhythmia was minus 24 milliseconds. And importantly, you can see that the pace mapping, the passo done towards the free wall of that apical recess comparatively with the septal aspect was identical. You can see that the correlation was 0.92 and 0.94, practically the same. What does this mean? It means that in terms of making a distinction of whether it originates in the free wall or in the septal portion of the apical segment, the pace mapping will not be useful. It has a limited resolution, and basically this is a very narrow area where basically with the beat, the catheter, with the pacing, we can capture the septal portion at the same time as well as the portion of the free wall. However, it is very important to be able to distinguish what aspect of the apical recess the arrhythmia is coming from. In this case, you can see the vector pointing towards the free portion of the apical recess. You can see it here on ice, and the procedure was a failed procedure. When we have failed after having 20 grams, 30 of power in the tip of the apical recess and 0.92 of correlation on the pace mapping, what can we do? We can vote very quickly. If you wish, would you increase the contact force and power? Would you apply 5 minutes of RF? Would you go to the left ventricle, or would you go epicardial? ¿Me oyen allá? La mayoría de la gente acá.
Why don't you answer? Go and answer.
Oh, well.
I don't understand. So, respuesta AP. The majority say go epi, I think.
Go epi, right. So, en este caso, de hecho, ir a epi es lo que la mayoría probablemente se haría, pero en este caso, que fue lo que aprendimos exactamente, es que lo que hicimos fue cambiar la orientación del vector.
Perfecto.
Ustedes pueden ver ahora que el vector queda hacia la parte central del receso apical y el catéter queda hacia esta zona del ventrículo izquierdo, con lo cual lo que hicimos ya fue eliminar la taquicardia ventricular. Entonces lo que aprendemos de este caso es que fíjense en un espacio tan estrecho la importancia de saber si es pared libre o si es pared septal del receso apical, y eso solo lo podrás determinar en ecografía, si el tip del catéter apunta hacia pared libre o apunta hacia parte septal de este receso apical, y eso fue lo que se hizo acá. Esta fue la aplicación efectiva. Este fue el set final de lesiones, como pueden ver, libre y septal. Y voy a pasar rápidamente, este fue el segundo caso, en donde se ve el mapa idéntico, la zona precoz en la misma parte del receso apical. A diferencia, en este caso se pasó un catéter en el ápex del ventrículo izquierdo, catéter al ápex del ventrículo derecho, y por la vena interventricular un wire para mapeo unipolar. Durante la extrasístole,
During the
se
extrasystole,
hacen diferentes
different pacings are done during the PVCs, and in order not to take more of your time, the tachycardia began to change, and you can see from tachycardia 1, this one is more QS in V1, V2, and simply at the end, what happens is that we do an application on this area, eliminating the extrasystole. This is the third case, identical, with the same morphology, except that in this case we went epicardial, and an epicardial scar was found, a very similar set of lesions, and this is what I wanted to present. The technology helps in this case. You can see not only the vector, but you can also see a green tip that shows us where the catheter has contact. This is the left ventricle, and you can see that the tip is towards this area. And when we make the applications, from the right ventricle with the catheter oriented towards the tip of the left ventricle, you see the green dot in that area. And that's what we do from the apices of the right and left ventricle, and the extrasystole is eliminated. Conclusion, and to finish then, apical arrhythmias of the right ventricle have a reproducible EKG pattern, which is LBB with negative concordance and superior left axis, QS in inferior wall, and R in AVR and AVL. The right ventricular apex is highly trabeculated. It is a narrow recess, and it is delimited by the moderator band. It has a free wall in the recess and also a septal component. Intracardiac echo, deflectable long sheaths, contact force are extremely useful, not only to advance to the recess but also to map and ablate these types of arrhythmias. Our recommendation, we believe the most important thing, remember, is to have a good activation map. PASO helps, but not so much. In this case, the resolution is more limited, and we believe that the key in these cases is always to start with the septal aspect of the recess before starting with the apical. Obviously, a steam pop towards the free wall of the apical recess could cause tamponade. Okay, thank you very much.